Next, I call upon the Chief Instructor, Dr. Aparna. She's completed her fellowship from Aravind Eye Hospital, Tirunelveli, and currently she's a consultant orthoplastic surgeon at Chaitanya Hospital, Trivandrum. She will be talking about orbital inflammatory diseases, a Pandora's box. Over to you.
Good morning. Today let's try to decode orbital inflammatory diseases. Orbital inflammatory disease is an umbrella term that represents an etiologically diverse spectrum of conditions unified in their association with abnormal inflammation in the periorbital region. Presentation in 80% can be an acute onset of signs of inflammation, but in 20% cases it can be subacute with mild pain, and it can present as a mass lesion also. Rootman has classified it into two groups: specific inflammatory diseases and non-specific or idiopathic orbital inflammatory diseases. Specific can be due to specific causes like sarcoidosis or vaginous granulomatosis. Non-specific ones are space-occupying lesions which are non-neoplastic and non-infectious. Basically, it is a diagnosis of exclusion. Based on location, the IOID can be classified into diffuse or localized, as in myositis, dacryoadenitis, perineuritis, apical and anterior. The common one, myositis, that present with an acute onset of painful eye movements, congestion, chemosis, like that. Imaging shows muscle enlargement with involvement of the tendon. Dacryoadenitis, patient will present with congestion, tenderness over the lacrimal gland area, enlarged lacrimal gland. In about 30 to 50%, it can be associated with systemic conditions like lymphoma, sarcoidosis, GPA, Sjogren's, like that. So high index of suspicion is needed for systemic investigation and biopsy in case of dacryoadenitis. This patient who presented with multiple episodes of lacrimal gland area involvement, so we did an excision biopsy. Histopathology showed plasmacytic inflammation with storiform fibrosis, and immunohistochemistry showed IgG4 positive cells. So it is a new kid on the block, IgG4 ophthalmic diseases. Diffuse orbital inflammation is usually unilateral, present with repeated episodes of proptosis and ophthalmoplegia. It can be associated with reduced vision if there is associated perineuritis. Coming to the diagnosis, whether it is myositic or non-myositic, we have to do an imaging radiological evaluation to know what it is, and we have to do some blood tests that I will be discussing later. And if it is myositic, we can directly start a trial of steroids, and if it is responding to steroid, that we can include as a diagnostic criteria. Then if it is myositic, like lacrimal gland involvement or atypical involvement, we have to do an incisional biopsy in order to rule out associated systemic conditions. Blood investigations, if there is elevated CBC, ESR or CRP, we are dealing with an infective etiology. Then before starting steroids, we have to do blood sugar levels and rule out tuberculosis, especially in our areas, endemic areas like our place. Then we have to do ANCA, AC inhibitors, ACE, then IgG4 disease. If there is muscle involvement, we have to do a thyroid function test, because we know in thyroid eye disease there will be sparing of the tendon, but there is certain scenarios that can involve the tendon also in thyroid eye disease. So whenever there is muscle involvement, we have to send for TFT. Then if there is lacrimal gland involvement, we have to send anti-Rho or anti-La for Sjogren's disease, then RF factor and ANA profile. Then investigation, we have to do either CT or MRI, which shows that site of involvement like enlargement of extraocular muscles, enlargement of lacrimal gland, perineuritis or a tenonitis. Then if the patient is in conditions which are not responding, if it is showing a recurrence, if it is atypical involvement or non-muscular involvement, as in case of lacrimal gland involvement, we have to do a biopsy. And if the patient is already on steroid, we have to wait for a period of 2 weeks. And what is expected in a non-specific orbital inflammation is lymphocytoplasmic infiltrate with a mixed pattern of cells. But if there is vasculitis pattern, we have to think about GPA, send for INCA, look at the paranasal sinuses and renal function test. If it is granulocytic involvement, we have to rule out tuberculosis, sarcoidosis and fungal infections. If it is showing sclerosing pattern, think about IgG4 disease. About the management, in mild cases, we can start a trial of NSAIDs. If it is a classic pattern, we can start oral steroids, but make sure we have to give a full dose and we have to taper very slowly, because if we are under treating and if the condition is not responding, we may be clueless whether it is due to the under treatment or if it is something else which is not responding to steroids. And in case of intolerance or atypical cases, we can start with IV impure immunosuppressants. The sclerosing variant, which shows poor response, may need immunosuppression or a radiation therapy. Methotrexate is a relatively safest immunosuppressant, but in cases like GPA, which can be life-threatening, we have to give immunosuppressants like cyclophosphamide. So this elderly gentleman who presented with features of inflammation, without imaging, somebody has started on steroids, but on imaging there was a huge mass which was crossing the midline, so we did a biopsy. It was a non-Hodgkin's lymphoma B cell type. So sometimes orbital inflammation can masquerade the underlying neoplastic conditions also. So my take-home message is, we have to take a detailed history and meticulous clinical examination is must, and do not hesitate to do a biopsy when it is indicated, and do not undertreat when you are giving a trial of steroids, because that may make you clueless regarding the further steps in the management. Thank you.
Thank you, Dr.